I'll be chatting a little bit about a line of research, an area of research that is particularly important, we think is particularly important. We've been working on for the last 2 or 3 years, actually. I'm going to tell you a little bit about what it is, or why we think it's important, and also a little bit about how we currently manage it, and possible extensions as to how I think might be the future of the management of this issue, let's call it. Let's not call it condition, multimorbidity. But let me start by saying that in many ways, multimorbidity is actually a story of success, a success of modern life in a way, not only of medicine. And the reason why I say that is that about 100 years ago, the causes of mortality were actually very different to what we have nowadays. In 1900s, the top 3 causes of death were infectious diseases. There were things that you could pass to each other, for example, pneumonia and flu, tuberculosis and gastrointestinal infections. And over that period, in the 100 years since then, that has changed dramatically. We now have managed to control fairly well infectious diseases. And now the top 3 causes of mortality are what we call non-communicable diseases, things that are actually more suited to lifestyle or other factors like genetic factors that might cause it. And there is a critical difference as well. So we have these 3 new potential causes of mortality, or top causes of mortality: cancer, heart disease, and cerebrovascular disease like stroke, for example. But not only are these the causes of mortality, but we're actually quite good at managing them as well. So even someone with cancer can end up being alive for many, many years, even with non-remission. So we've managed to convert some of these potential killers into what we would call chronic diseases, and I'll tell you a little bit more about that in a minute. Not only have we been changing, or has in those 100 years, the type of, or the causes of mortality have changed dramatically, but also we've managed to reduce not only the causes, but also the numbers, the total numbers of deaths. So we were looking in 1900s, out of, let's say, 100,000 people, you would be expecting around 1,800 cases of death, 1,800 deaths. And by 2010, that's decreased by more than 50% to close to 800. And what this figure is telling you and showing you as well are the different causes. So here we have, in 1900, top causes being in blue, which are infectious diseases. Still, chronic diseases were important, but not as important as they are now. As you can see now, roughly, there's been an increase both in cancers and heart diseases. And it's mainly because there's been a substantial change. People are living for much longer. How much longer? Well, if we look at, for example, data in the UK, in 2016, we would expect someone that was born in 2016 to reach about 80 years of age. A little bit more if it's a woman. But what's important for this particular talk is that not all of that time would be expected to be spent in health. So a substantial part of it, we would expect it to be healthy, around 63 years. But the last few years of your life, we would expect it to have some kind of condition, some kind of ailment that will be giving you some kind of impairment. And that roughly translates to about 15 years of living unhealthily. If we were to look at the trajectories over the last, let's say, 35 years, we would see that there's been a gradual increase for both men and women. But interestingly, men are catching up in that disparity in terms of the total life expectancy that we would have at birth. And if we are looking at this 35-year period, women would be gaining around 2 months per year of extra life, if you want, by 2016, while men are gaining around 2.5 months per year. So it's a little bit of a catch-up for men. Having said that, we think in many countries this life expectancy, or increasing life expectancy, is reaching some kind of limit. I imagine you have seen in the news, for example, in the UK, some of you might have seen in the news that in the UK that has actually been reverting, probably. We think that that's been reverting in the last few years, and there's some questions as to why that's happening. Similar things have happened in the US, while other countries seem to actually carry on increasing their life expectancy. We have data, for example, in Japan, it seems to be increasing still. And curiously, Spain is one example of actually a success case. And they are expected to actually take over Japan as to the country with the highest life expectation in the near future. Going back to this idea of having a time of your life spent, out of the total time of your life, some time spent in ill health, this graph is showing the proportion of your time that you would spend in good health compared to the proportion of your life that you would spend in ill health. In the last 15 years, there's been an overall increase in life expectancy of about 2.5 years, going from 80 to around 83. Out of which 1.5 of those were spent in good health and around 1 in poor health. So in terms of the ratio, sorry about this, I'm a statistician, so I'll be giving you a lot of statistics about this. In terms of the ratio, more or less the same amount, same proportion of time is spent in good health compared to in 2000 compared to 2012-14. So the positive side of things, we would say, well, we're actually living for much longer. If we want to be negative, we might say, well, about a quarter, just under a quarter of our life is spent in poor health. Now, for those of us who are in our second part of our lives, this slide probably doesn't give us a great deal of cheer. And this is because the increase in life expectancy after 65 it's mainly in years gained in poor health. And this is something, obviously, that we would like to do something about. We're working quite hard to change it. Not necessarily in terms of getting, in some cases, actually fixing or dealing with the condition itself, but in other cases, as I'll explain in a moment, managing the conditions. Now, what I've been telling you is that we'll be living for longer. And then probably it's no surprise that we live for much longer, anything between a couple of years to, if we go back to 1900s, several, maybe a decade or so. You will find that as we live longer, we will end up accumulating different conditions, and that's where multimorbidity comes into play. Having said that, the definition of multimorbidity is a little bit vague. I'll give you two of them in this talk. This one is probably the most widely disseminated. It comes from the Academy of Medical Sciences. And the definition is the coexistence of two or more conditions. So they appear in the same person at any point in life, and because they're chronic, will remain present for the rest of their life. They go on to define what they mean by chronic. It could be either a physical, non-communicable disease of long duration, such as a cardiovascular disease or cancer, and stays there for longer. It could also be a mental health condition of long duration. Could be, for example, a mental mood disorder or dementia. Someone with bipolar, for example, would be classified as having a long-term condition. Or it could also be an infectious disease of long duration. HIV has changed in my lifetime from an acute condition that was almost definitive death to something that we can manage, and people with HIV, HIV positive, are seen to have life expectancy similar to anyone without that condition as well. So this is a current definition that is more commonly used. Another definition that is much wider is by Lereste et al. That talks about multimorbidity as a combination of a chronic disease, again this idea of chronic, something that lasts for a long time, combined with at least another disease, and this could be either acute or chronic. They don't even define what chronic is or acute, so any kind of disease, or a biopsychosocial factor. And when I first read it, I wasn't entirely sure what they meant. What they mean are things like, for example, poverty, stress, or addiction. Those are different types of biopsychosocial factors. But what's crucial in the rest of the definition is that the combination of the chronic disease and anything else modifies the health outcomes, leading to an increased disability or decreased quality of life. So we'd be thinking of multimorbidity in this particular case as not necessarily just adding up the different conditions, but when the conditions are actually having a bigger impact. So you can think of them as a new condition in many ways. But this has important problems. I was just looking at the BBC yesterday and found this particular definition. So there's a philosophical element to it. What counts as a disease? I'm not going to go into details. But there might be some specific examples I'm going to give you where people agree that we are looking at a person, in this case, with multimorbidity. Let me give you 3. So the first one, we're looking at a 42-year-old woman that went to her doctor and was diagnosed as being diabetic. She was asthmatic, or she was diagnosed as asthmatic when she was 12 and still carries an inhaler with her, although she rarely uses it because she believes that her asthma is within control. But having heard the news and hearing that she is diabetic, she feels anxious and depressed about what this new label is going to mean in her life. So she has anxiety, depression, is asthmatic, and now also diabetic. Another example. This is a woman who's 65, and she goes to her GP and is just on a routine check. They measure her blood pressure, and they find out that her blood pressure is above a particular threshold, so that she is diagnosed as having hypertension. So she has high blood pressure, and therefore her GP decides to give her medication to deal with that. So antihypertensives try to reduce her blood pressure to a level that they believed to be adequate. She starts taking the medication. 2 months later, her blood pressure goes down and she falls. And she happened to have osteoporosis, which had not been diagnosed, which means that she fractures her hip. So suddenly a diagnosis or a condition that was not diagnosed interacts with a medication of a diagnosis that happened, and we have obviously substantial morbidity. Final example. We have a man, 72, who when he was 45 was found to have an enlarged prostate, which meant that he got very anxious, so started drinking to deal with it. A few years later, maybe because of the drinking, maybe because of other lifestyle issues, they found out that his blood pressure was really high. They tried to deal with that blood pressure, didn't manage it properly, so he found 3 years later to be diabetic. By around he was 50. Wasn't well managed, so he got nerve damage. He cannot feel his toes, he cannot feel his fingers. And then at 69, he gets diagnosed with Parkinson's and finally heart disease at 72. So we have a very complex case, in this case, with prostate, anxiety, high blood pressure, diabetes, Parkinson's, and heart disease. This might seem extreme, but the reality is that if we live long enough, most of us will end up having a very similar profile to this person. We'll be accumulating all these different conditions. Now, I've just, in a way, explained how there's a strong association with long life and multimorbidity, that is, having more than one condition. Let's define it like that, having more than one condition, 2 or more. There's been a series of studies. This graph shows you in different colors each one of these different studies carried out in different populations, some in the US, for example, some of them in the UK. And what they're showing is how, as we move up in the different age groups, so we go from 20, 40, 60, all the way to 100, how the prevalence, which is basically the proportion of people in that particular age group that have the characteristic, in this case, that have multimorbidity, how the prevalence is going up. So as we live longer, we would expect more and more people to have multimorbidity. Roughly speaking, the study by Barnett, which is the one in red, will tell us that by the age of 20, or what they calculate is by the age of 20, roughly 10% of the people, 12% of the people, 10% of the people will have multimorbidity, compared to the same population by the age of 60, we're looking around 40% of people to have multimorbidity. If we were to look at a slightly different study, the one by Nascence, which is the top one in yellow, there's a substantial disparity in the calculation of multimorbidity. They claim that at 20 is close to 35%, and by the age of 50 is close to 80%. Some of these differences are due to the population, so the fact that they're looking at different groups of individuals. But it also related to the lack of a consistent definition across these different studies. So that makes actually studying this particular issue complex. Let me give you an example of the type of work that we've been doing in the BRC. So in this case, we looked at data from GP records. And we tried to work out, given all the individuals that have had a heart attack and survived, so they've had a non-fatal cardiovascular event, let's call it a heart attack, and survived, if they have multimorbidity, how many other conditions they have besides the fact that they had a heart attack. And we looked at them over time. In 2000, the number of people that had 0 conditions, apart from their heart attack, was around 15%, and that's decreased to about 5% in 2014. While on the contrary, the people, or the proportion of people that have 5 or more has shot up to around 40%. You would say, well, maybe it's because we're getting better at diagnosing. That's possibly one of the reasons. The other reason is obviously the aging population. But what's interesting in this particular study is not only the fact that we are accumulating conditions, but also which conditions we ended up looking at. And in this slide, what I'm showing you is exactly the same study, breaking down the different types of conditions that were present in that particular population. And some of the suspects that you would have for heart attack are there, things like hypertension, which means high blood pressure, or hyperlipidemia, which means high cholesterol, are there. But there are other things that we wouldn't necessarily have associated with heart attack. Depression, arthritis, asthma, anxiety are some of the top causes. So that's the sort of thing that we try to evaluate and try to work out, well, if these are happening commonly, what will be the potential effect? Can we deal with it in a better way? Now, I told you why we care. Well, we also care because it actually costs quite a lot of money to manage people with multimorbidity. If we look at the expenditure for long-term care, managing long-term conditions, multimorbidity, long-term conditions, it's around 2% of our GDP. It's around 50 billion per year. Most of this is paid by the government, so it's part of a public health element, but a substantial part of it is also paid by the individual. Roughly 30% is paid directly by your pocket. You're paying for services and medication. If we assume that that's, just to give you a bit of a handle on this, if we assume that all the working population, 35 million of us, were to pay this amount, that will translate roughly to about £400 per year that we spend on managing long-term conditions per person. Well, we spend a lot, we've been studying it. Are we good at managing these? What do you think? Well, the answer is we don't know. Or it depends. Why? Because in example 1, we're talking at someone that had maybe was asthmatic, but had their asthma fairly well controlled, has just found that they have diabetes. We can work out, because there's some markers that we can use to work out if her diabetes is actually well managed or not. So we would be able to tell you if this person is actually within what we call control, a little bit more of that, or not. But if we're looking at a man 72 with multiple conditions, it would be actually quite hard to say, is this person well managed or is not? It's actually very tricky. And that has to do a little bit with the paradigm that we've had to deal with so far in medicine, how we diagnose disease. And it could be things like, for example, imaging. We look at CT scans that allow us to diagnose things like cancers or hard and soft tissue problems. We might diagnose people using clinical diagnosis that could be based around a combination of signs and symptoms like colds, asthma, generally speaking. Or it could be based around biomarkers, and probably the classic example would be high blood pressure. We use something called a systolic blood pressure, which is measuring a particular sort of way, and if it's beyond a particular threshold, usually 140, and that's that line that appears in that graph. If it's beyond that threshold, we would say that person has hypertension, and we need to manage it. They are on the extreme. They are high risk of something happening to them, and we want to bring them back to the center of the distribution. We want to bring them back to normal. And you're probably not surprised to hear that there are many of these chronic conditions that are actually managed and diagnosed in this particular way. Diabetes being another one. How do we deal with diabetes? How is that diagnosed? By the use of basically blood glucose. we use something called glycated hemoglobin, or HbA1c. The acronyms are horrible, let me tell you. It takes probably about 5 years to just start getting the hang of the acronyms. But anyway, so we look at the glycated hemoglobin. If it's beyond a certain threshold, in this case above 6.5%, we would say that person has diabetes and we need to bring them back into line. And there are conditions, I told you, for example, that asthma is managed and diagnosed using signs and symptoms, but it could also be managed using some other measures, like, for example, something called FEV1, or forced expiratory volume in 1 second. This is usually how hard you can blow to it on a tube. And if we were to replicate this model across many of the conditions for that, for example, for the man who's 72 and has Parkinson, enlarged prostate, etc., we'll be in a situation where all these different measures are present. They might be, in some cases, we want to manage all of them at the same time, but it might be very difficult to decide which one to focus on. Why? Because there might be, or in many cases, there exists contradictions. That is, if we try to bring one down, bring one to the center of the distribution, that might mean that we're pushing another one to the extreme of the distribution. So which one to deal with first? And it's tricky. There's been proposals of how to do this management. This is one graph of a paper we published in 2014, in a way giving some advice to GPs who are generalists on how to manage multimorbidity. And generally it's generalists, either GPs or geriatricians, who end up doing this management, because if we look at specialists, they focus on one particular characteristic or one particular condition. And it's tricky because, in a way, there are so many things that you need to look at that you need to define a plan looking at the whole of the individual and talking between the doctor and the individual, define what's most important for them. There might be some issues with the interaction, as I was saying, between the different medications. There might be too many medications to take. Individuals might be taking, 30 pills in 1 day. That's not uncommon. And that will obviously would affect how we plan or manage this individual. Not only that, if there is a change, for example, a change in the condition or a new condition coming in, we need to reevaluate this plan. So this sounds okay, but there are very big challenges. What are they? Well, at least from that framework, we need to find out how do we define these targets and goals. It's not straightforward. As I was saying, there might be too many things to look at. We need to find ways to encourage new and better practices. How do we convince people to keep on the medication or to start taking exercise or to stop drinking alcohol? And also we need to, in terms of the research, how do we improve our understanding? How do we know that a particular intervention is effective or not? All of this in a system that's actually at breaking point. The person-doctor interaction is actually, it's not increasing in terms of the resources, but it's increasing in terms of the pressure. A work that we carried out in, when was it? It feels forever. 2017, I think it was, showed that for all measures that we looked at, GP workload was increasing. Things like GPs are working more days, people are attending more times to GPs, both face-to-face and telephone consultations have increased, and the total amount of time spent in consultation has also increased. So, and I'm sure you've heard anecdotal evidence of general practice surgeries closing down because people don't want to go into GP anymore. So what's happening? How are we managing multimorbidity? Well, in many ways, we're going into this idea of trying to identify when an individual is within control. Some of you might have seen these devices. In fact, some of you might have used them already. What are they? They are what we call point-of-care tests, or devices that can be used either at general practice or by the individual themselves to measure something that is related to the biomarker or the disease that we're looking at. The one on the far left is a blood pressure machine. So we put a cuff, we find out within a few minutes what will be your systolic blood pressure, what will be your diastolic blood pressure, and you can work out a target and find out if your blood pressure is well managed or not. And similar things we can do for other conditions. On the far right, we have a device that measures your blood glucose. so we can work out if, again, you are within range or not. And in the middle, we have a device that measures FEV1, so how well your asthma is managed. And these devices can be either, as I was saying, in general practices or being used at people's homes. And the way they're used is to determine if the trajectory over a particular period of time is such that we would say there's obviously going to be a lot of variation. Each one of these gray points, I hope all of you can see them, each one of these gray points are actually sort of valid data points. They're valid levels of the systolic blood pressure for that individual. But over time, that person is at the right level. He hasn't actually shown the variability beyond what would be expected, and we would say that person is within control, is well managed. As opposed to, if we were going to look at their trajectory, and we see that that's increasing over time, we would say, well, that person, earlier on we might be able to detect it's not going to be well managed, it's going to be beyond what that threshold we wanted them to be. We need to bring them back. We need to, for example, give them further medication, or we need to ask them to start doing something different in their lives. And just like we have these trajectories for things like systolic blood pressure, we can have them as well for all the other, as long as we have a scale, for all the other characteristics. We can have it for diabetes, determine whether they're in control, for asthma, determine whether they're in control, and as long as we have a scale, we can do it across all these different scales. So we might have a way to start managing, say, well, we have defined that you have all these different conditions, but using measurements based on you, we can determine whether your condition is stable or not, or is actually deteriorating. But there's still some questions that need to be addressed in this case. For example, who should be checking these trends? How can we interpret them? What should we do on the basis of this information? What if the trend goes high and the others are stable? Should we change? Should we remain the same? The reality is that we do have all these measures, and the way they're managed is haphazardly. As I was saying earlier on, it's based around specialists looking at a single trend, maybe in many cases forgetting about the others, and deciding to change treatment based on one or maybe a couple of these trends. In the case of generalists, in GPs, there's also that's the alternative, but there's sometimes not enough time or expertise in many cases to do this management. What has happened is that in many cases it's down to the individual, what we call self-management. You look at all the different information and decide to make changes that in a way suit you. This is as long as you are able to, you're not dependent of another person, in which case it might have to be the carer who deals with this issue. But again, it's very it's everywhere. I think what we need, one of the current proposals I bring is that we need an integrated system that brings together all these different scales and trends and measurements. A similar thing exists for maybe not everything that I want to include in what we call intensive care units. So some of you might have seen this either in TVs or in the hospital themselves. And they're monitoring devices that tell you if all the signs, all the clinical signs and symptoms, heart rate, etc., are adequate for that particular person. And if something goes astray, then there's an alarm immediately, and we need to change that. Okay? But as I was saying, this would be of use if we have a marker that we'll be able to use to include in and find out what's happening, whether people are in control. And that's not available for everything. So we know, for example, that in case of cancer and in case of many conditions for mental health, we do not have these markers yet. Having said that, there's still a big effort as part of, the Biomedical Research Center to find biomarkers certainly for cancer, and in a separate biomedical research center, the Oxford Health Biomedical Research Center, I think it's called, for markers for mental health as well. We might be able to use also, instead of markers, biomarkers, alternative types of data. For example, we now collect or have available imaging, or they might be, for example, a phone might be able to capture how fast you type, how fast you text, or, for example, facial recognition, or how you walk. And it might be that type of data that we need in order to integrate to find out on alternative types of conditions. Some people have also highlighted the role of omics, either genomics or proteomics. It's still a little bit unclear what information that will provide us, and if that information will be more than what we would be able to get from more readily available sources like high blood pressure or cholesterol, let's say. But what I believe is that we are, in many ways, at a threshold. We have new devices that are being created, that are generating relevant data. We probably need to determine what data is actually critical. And in many cases, some of these devices might need to be created. We need to find new methods to store and create information, create relevant information from the data that has been stored. And we need to create, probably this is the most difficult, an adequate flow of information that will allow users, health providers, and policymakers to use this information to make relevant decisions. And I think at the cornerstone of all this, I think we need to have an ethical discussion about who owns the data. There are issues about what are the limitations, what are the extensions, and what should we be able to do and not do with the information. Maybe a new social contract is required. And if I'm talking about managing multimorbidity, well, we can think of doing exactly the same thing when we are not diseased. So when we are in our teens or in the 20s, you can still identify what is the right trajectory for you and determine earlier on if something is changing and define lifetime trajectories while you're still healthy. You might think this is ridiculous, this is too far. Well, it's already in a way happening. We have loads of wearables in the market already providing us with information about heart rate, blood oxygen levels, even stress and emotion. We have them already there, but they're only available for those that are, in a way, they have the resources. And I think that's actually generating further disparity in our healthcare system. So in conclusion, multimorbidity is a problem caused by the success of modern life. The rough definition is having two or more conditions that interact. The way we manage, or the way we deal with multimorbidity, is based around definitions of control. And we would be able to use this definition, this approach to the management of most conditions, but not all conditions have a way of measuring whether that person is within control or not. If we were able to do that, I think we'll be able to manage multimorbidity and, by extension, manage health. Some of the tools exist currently, but they are very expensive. And I believe, as I was saying, we might need a new social contract to define who collects the data, who keeps it, and what we're able to do with that. And let me finish by just giving you two quotes. The first one is by Charles Kettering. It's a very optimistic approach. My interest is in the future because I'm going to spend the rest of my life there. The alternative by Philip Roth is, old age isn't a battle, old age is a massacre. Well, we hope to provide at least some of the ammunition. Thank you very much.